Chapter 44, Nursing Care of the Child with an Alteration in Mobility, Neuromuscular or Musculoskeletal Disorder. In this chapter, we're going to talk a little bit about the differences in kids and adults as far as anatomy and physiology goes. We're going to talk about a few of the neuromuscular illnesses in childhood. We'll talk a little bit about the impact on the kids. We're going to compare some of the anatomy and physiology of children and adults. We're going to talk about a few of the tests that we do. We're going to talk about some interventions in nursing assessments with kids with musculoskeletal disorders, and we're going to talk a little bit about recognizing them and then the impact. So there's several types of neuromuscular disorders. We see traumas, so hypoxia to the brain or spinal cord. We'll see some genetic problems. We'll see structural abnormalities. There are some that are autoimmune in nature, but each has some type of effect on their development and motor skills. So we see sprains and strains because they're less likely to break things. They have better soft tissue, more resilient. The biggest thing with any type of neuromuscular disorder and musculoskeletal disorder is early intervention will yield the best outcomes. So some of the variations in kids, when we think about the differences, their brain and spinal cord are forming. In the first 3 to 4 weeks, the brain and the spinal cord are differentiating. And so any type of infection or trauma or malnutrition on the mother's part is going to cause some problem in growth and development of those areas. Their spinal cord is more mobile, so therefore it's more at risk for cervical injury. Myelinization is not complete until about 2 years old. That full range of motion is present at birth. It's just they don't have that purposeful control of movement. We see sluggish DTRs, and that could usually indicate something's wrong. And then we see hypotonia or hypertonia, and those are abnormal findings. And there's a little picture depicting the two. So when we think about muscular development, we talk about tendons, ligaments, cartilage. We see a lot of injuries in kids. So as far as kids go, their skeleton's not fully developed at birth. They're not fully ossified. Their bones are more flexible and more porous. Because of the growth plate that they have in their bones, we see a greater shock absorption. So the bones will bend rather than break. It's pretty hard to break kids' bones, especially the smaller they are. They have a strong periosteum, and so there's a greater absorption of force. Some of the spine problems at birth, they could have a kyphosis, which is an outward curvature, or lordosis, which is an inward curvature at the cervical area. They seem to grow out of those as they go on. As far as the growth plate's concerned, the ends of the bones are the epiphysis, and that's where the growth plate is. And then eventually those will ossify over time, but in infants, they are more cartilaginous. So if they get an injury at the growth plate, it's very important that it's repaired. They have an abundant blood supply. And then as far as healing, bones heal more rapidly in kids. They produce callus more rapidly, and so the younger the child, more quickly it heals. Also, the closer to the growth plate, it's going to heal more quickly. The problem with this healing so quickly is if they are not aligned properly with a cast splint, then it's going to heal quickly and the damage will be done. So monitoring those devices is important. Children don't always keep casts on, and so that's a problem. We're going to talk a little bit about casts. So they're used to immobilize a bone that's been injured or displaced. It's going to hold it in place. Typically, when a child comes to the ER or go to the doctor's office with a broken bone, they will, two words that we use are reduction and retention. So reduction is we have to reduce that open space if it's a displaced fracture. So you can see in the oblique fracture, it's displaced. So they have to bring those two pieces together. Same with any type of fracture. If there's any space in between the two broken areas, they have to bring them together, and they call that reduction. Retention is holding it in place. So if they come to the doctor's office or the ER or something, they will put the bone back in place, and they will typically not put a cast on right away. They'll put a splint on because the splint will allow for swelling. Gone are the days when they put the cast right on, because then we had problems with kids' hand swelling, pain, and so we would have to cut the cast off at that point. So now they put a splint on, which is sort of like half a cast, ace wrap, and that way sensation and movement can be checked. Once a couple weeks are down the road, they will re-x-ray the limb, and then they will put a cast on there. And that really depends on the type of injury, the severity of it, as to how long that cast has to stay on. Splinting, like I said, that's temporary support of an injured area. We have fixation, so we have internal fixation and external fixation. The picture you're seeing here is internal fixation, and then there's a cast on top of it. So pins, screws, rods, things like that. External fixation would be some type of a device on the outside of the hand or arm or leg, wherever the injury is, and it allows for the physician to adjust the pressure and the placement of the external fixation. We don't see that too much in kids. Other things, you could have cervical traction if you have a C-spine injury. Crutches are weapons for kids, so being very careful when you're doing crutch teaching, because they do adapt easier than adults, but they also get a little wild with them. So kind of letting them know it's not for playing. Traction's another way where we would use immobilization to reduce or immobilize a fracture. They want to align it. It also reduces pain when we put them in traction if we can't do the surgery right away or reduction right away, because it reduces the muscle spasms, so they don't have as much pain. And we talked about external fixation, where you can actually see things. We're going to talk a little bit about some skeletal development. We talked a little bit about the skeleton not fully ossified at birth. And one of the big things that we see is bow legs at birth, and they'll eventually grow into those. And then the picture here is just talking about the growth plate, and then the mature bone and the immature bone. Some congenital neuromuscular disorders. We talk about spinal bifida. I'm sure you've heard a little bit about spinal bifida. I think we mentioned it in another slide. So there's quite a few different genetic neuromuscular disorders and neural tube defects, which is what spina bifida is. Congenital anomalies are usually identified at birth or in utero, and then they're able to think about, repair for these. Neural tube defects. Spina bifida is an opening into the spinal column, and so usually when that 3rd to 4th week of gestation, there could be factors such as drugs, malnutrition, chemicals, genetics, and that will hinder the development of the spinal column. What's really helped, like I mentioned before, was folic acid for all women of childbearing years, and then the repair of a spina bifida. So we have different levels of spina bifida. Those words are really not clear. So you have spina bifida occulta, and that's in a disorder of the spinal cord, and it can be confusing because They look like they're fine. They're moving everything, but there's some kind of just like a little hair tuft there or an indentation, and that can be an opening into the spinal column. You have your meningocele and myelin meningocele, which we discussed in a prior slide. The basic thing is that surgical closure is performed because, especially if there's a CSF leak, you want to prepare for that. And then also early surgical intervention to really minimize the loss of function, because if you didn't repair that, they could be paralyzed. They could have loss of bowel and bladder function. And so early intervention, early surgery is going to be better for them. They say that to make sure you're using all latex-free catheters or gloves with kids with spina bifida, because they can exhibit a high incidence of latex injuries. Some of the developmental problems we see are clubfoot, so congenital clubfoot. It's a congenital anomaly. It occurs in quite a few births, like 1 in 1,000. There's different levels of clubfoot, but basically the foot represents the head of a golf club, and then they can be postural because if it's a big baby, maybe in utero, that foot was in a different position. It could be idiopathic, which means we don't know. It can be neurogenic. So what the goal is it to get that foot to the normal position so that they're fully functional with it. They do what's called serial casting. So starting out casting, moving the foot in a little bit each time they change the cast. They don't want to turn it all the way in. So they'll just do slight turns and put casts on. These casts can kind of be a problem sometimes. There is an opening for the genital area, but a lot of times when kids have like poop or pee blowouts, it's going to affect the cast integrity, and that would have to be replaced. Also what we think about with club foot is even after the surgeries, serial casting, they will also use ankle foot orthotics or corrective shoes for several years to keep those in place. Osteogenesis imperfecta, we call it brittle bone disease. It's a genetic disorder, and it results in low bone mass, so they're at risk for fractures. Sometimes the first time that they realize that they have osteogenesis imperfecta is when the baby comes out. They do some vigorous stimulation and drying off of the baby, and they could break bones at that point if they don't know what's going on. Also, the tooth enamel wears easily, and their teeth are brittle and have discolored teeth. It's usually a defect in the collagen type 1 gene, but autosomal dominant. So kids, it's not as common as people think. And sometimes people will say, they're having, being accused of child abuse or something. They'll say, oh, my child has OI. Well, that's a birth diagnosis, so it doesn't just happen later in life. And a common finding is blue-gray sclera. And so they don't, newborns sometimes have that anyway, so just be careful that you're not accusing or letting them know that they have this, because it could just be that newborn sclera, so you want to wait a little while. You can see a healthy bone, and then you can see the brittle bone. So I've taken care of kids with OI, and I've, from birth until like 5 or 6, they've had hundreds of fractures. So you got to be really careful with like a blood pressure cuff, anything that you're going to do, the tourniquet, things like that could cause a fracture. Developmental dysplasia of the hip. So this is abnormality of that developing hip. It can be dislocated. It could be subluxed. It can happen during childbirth. They're usually, we could tell, is when we stand the child up as an infant, and we can see that the gluteal folds are not even. So your gluteal folds is that crease underneath your cheek of your bottom, And those would be uneven. We could tell that way. Also with x-ray, we can tell. And so they would do some surgery on it, or they would just put them in a harness. There's some pictures of different kinds of casts and harness that they would use. But usually if they put them in a spica cast, it's worn for about 12 years. And then if they don't respond to the treatment using the cast or the harness, they would go ahead and do surgery after a couple of years. Spinal muscular atrophy, so we call it SMA. It is a genetic motor neuron disease that affects the spinal nerves. It's inherited. There's really no cure for SMA. There's different types of it you can see on the screen. So different types would tell you, what you might see. So type 1 would be before 6 months and they're not meeting their milestones. And then it goes on from there. There is a lot of research in this area. I've taken care of a couple SMA kids. The problem is they're just not compatible with a long life. The respiratory muscles are eventually going to become weak, and then that's usually the kind of death that we see in the type 1 SMA when it's diagnosed early on. And they seem to get a lot of upper respiratory infections. They can aspirate, and then some also have other signs and symptoms, narrow chest, things like that. So it's a very, very sad disease. There's a couple that have 2 kids with it, and the one was recently diagnosed when I had seen them a couple years ago. And there is some medication now that they can, that they're trying. It's like a trial to see if it will decrease the progression of the disease. Cerebral palsy, we talked a little bit about cerebral palsy when we talked about hydrocephalus. It's a term that we use. Cerebral palsy are symptoms. It's non-progressive, meaning that the injury happened in the brain and it's not going to get any worse. However, as a child grows, we might see different signs and symptoms, but it's not going to get worse. So abnormal brain function could be before delivery, it could be during delivery, it could be post-delivery. It's one of the more common movement disorders. Usually kids will develop signs, symptoms early, limps, ataxia. You can also have complications with CPs like mental impairment, seizures, growth problems. Some kids can progress to a fairly normal life with some accommodations. Some will never be able to progress. So it really depends on the extent of the injury in the brain. So management is always trying to get them to the highest level functioning that we can. And also we talked about hydrocephalus, so putting shunts in, things like that. So it's rare, it's a range of non-specific symptoms. So you could have one person with cerebral palsy and not another. It's that non-progressive abnormal functioning. It's classified in different ways depending on the area of the brain. So growth and development, safety is really important, mobility, optimal nutritional intake. Sometimes these kids have feeding tubes in to increase their nutrition, and then support for the family. One of the complications of cerebral palsy is that pathologic drooling is a problem, and that can lead to dehydration. It will damage their teeth. So enamel erosion, they'll have a terrible odor with it. And so there's been some research on Botox injections to improve the drooling or decreasing the side effects. So that's something new. They also can do surgery to cut, I guess it is the salivary glands. Some acquired disorders. So acquired disorders is resulting usually in nutritional defects, deficits. So rickets is one of the big ones that we think about. It's a lack of calcium, vitamin D, so not enough sunshine, and they'll have the bowed legs, or they'll have just their bones are softer, so you'll be able to see protruding bones, things like that. That's in the picture. Management is always to get them to the highest level of care and to increase their vitamin D. Skiffy, so slipped capital femoral epiphysis. We call it skiffy. It's where the femoral head dislocates. And we see this in that teenage years when they're having their growth spurts. Also, kids who are obese, the pressure on that can make it slip. See a doctor for that. They will do surgical intervention with pins and screws to put it in place. And then again, you want to get them to the highest level of functioning that they can. Leg calf purse disease is another injury or another disease is avascular neurosis of the femoral head. So usually affects kids about 4 to 8, but it can happen earlier. And they're not sure why it happens, but it's just an interruption of that blood supply of the femoral head. So pain, they will try to give them anti-inflammatory medication to just so the kid can handle it. And then they, everybody has a little bit different pain and a little different area of range of motion, so they'll monitor that. And scoliosis, we talk about scoliosis. So you remember in grade school, I think they check your spine to see if it's straight. And if they have a mild curvature, they will do just monitor it as they grow. If they have a major one, they would do surgery. And then if they have something just in the middle, they would do braces and a brace, and they'll watch that. So here's your leg calf purse disease, so avasculosis of that femoral head, and the skiffy is here, so it will result that epiphysis or the growth plate, so needs surgery. Spinal cord injuries, so we see spinal cord injuries for lots and lots of different reasons. In kids, we see them from falls, trauma, any type of fracture where the child, any type of fracture can be abuse, but spiral femur fractures, rib fractures, humerus fractures are under 2 are usually always abuse, and you want to be investigated. So we see more of the spinal cord injuries. It says 16 to 30 years old. Those are the increased incidence of accidents, more risk-taking behaviors in that area. I took care of a girl who was paralyzed. She had jumped off a rock in like Spinal Canyon or something, and was drinking and didn't realize that it was so shallow, hit her head and was paralyzed. There was also a situation a couple of years ago where 2 16-year-olds were in the back of the car. Parents were driving. They were in an accident, hit pretty hard the car in front of them, going at a high rate of speed. And the girls had both taken off their shoulder harness for their seatbelts. And so when they went straight over, and they fractured their spinal column and were paralyzed. So those shoulder harnesses are there for a reason. But depending on the injury site is where you'll see more signs and symptoms. So the higher the injury, the greater loss of function, obviously. If you have injuries above C4, then those are the people would be on a respirator, because the respiratory muscles will be paralyzed also. They have temperature regulations. They usually have bowel and bladder problems. So really depends on the area and the severity of the injury. So to prevent, we talk about vehicle safety. So wearing seatbelts, car seats for kids, helmets, prevention of falls, violence prevention. We've seen some spinal cord injuries from guns, and then water safety, again, diving into shallow pools. Fractures, we talked a little bit about fractures before. I put a slide up in the beginning of different types of fractures. One of the ones we see in kids is called radial head subluxation, and that is a nursemaid's elbow. So it happens from swinging kids, and it's not that anybody's hurt them. It's just that the what happens with that type of injury is that pulling of the arm causes that ligament that surrounds the radial head to stretch, and then it displaces that radial head, and it becomes entrapped in that joint. So kids will come in not moving their arm, and so what the doctor will do is have the parent hold their one arm, and the arm that's injured, they'll hold a toy or popsicle, and when they go to grab it, they twist their arm a little bit, and that pops it back in place. It's not a fracture, it's not abuse, it's anything like that. It's just until that ligament gets stronger, it's just something that could happen. So immobility, so anybody who's mobile, you want to check circulation, sensation, pulses, turning them if they are like on a bed traction or something like that, looking at skin redness, range of motion, clean and dry, lots of fluids, and then coughing and deep breathing. When kids have casts, it's really important to teach them, actually probably adults too, not to stick things down the cast, because the arm or leg or whichever extremity is, it's very dry, the skin, and it itches, so they'll stick things down there, like they'll take a wire hanger and open it up and stick it down there. They will, just stick anything down there, so be very, very careful. And then, like I said, we put casts on adolescents before who go home and cut them off, and then the bone is not healed properly, things like that. Coughing and deep breathing if they are bedridden, obviously, also worrying about elimination status, because a lot of times they're on narcotics. And then long-term effect is stressful, especially if they can't get around, they can't go to school, and things like that. And then, like I said, if they don't keep the cast on properly, they could have some deficits. We had a kid who was constantly cutting his leg cast off, and over 2 years he kept cutting it off, and finally got to the point where the mother's like, forget it. And at that point, one of his legs was shorter than the other, and it'll be that way the rest of its life. Okay.